Okay, and I would like to open this meeting of the Opioid Advisory Board up at 10:04 on July 23rd, 2025. Uh, I'm gonna have everybody go down the line and introduce themselves and just tell them where they're from, so everybody will get a feel for that. We'll start with you, John.
John Myers, Edinburgh Town Manager.
Brian Gregg, Trafalgar Town Manager.
Jennifer Price, Franklin City Council.
Todd Shuck, Franklin City Council.
Kevin Walls, Johnson County Commissioner.
James Ramel, Bargersville Town Council.
Dennis Combs, New Whiteland Town Council.
Pamela Burton, Johnson County Council.
So you see, we cover the whole county here. So, the recap, I'm gonna give you a little recap. This is our second public meeting. This board was comprised of everybody across the county, and it's to use and grant the opioid funds that we've received from settlements that the federal government, states, everybody else has sued Big Pharma. So we've had one round. I think it's went really well. And today we're going to kind of look at getting a report from some of the recipients. And I know there's going to be a new ask because this is another grant cycle period we've got. So we just like to keep it informal and just bring it to us. And we will not make any decisions today. We will have to push it in front of the whole commissioner board to make the final decision. But that's the way today's going to go. So with that said, does anybody want to add anything to that, or is everybody good with that?
Good.
Okay. So first up is upstream.
Thank you. Is it on? Can you hear it?
Yeah, Connor's probably got it on.
Maybe.
Sometimes you got to get real close to that mic.
Shove it down right in my face.
There you
How
go.
about that? Yeah. Thank you for having me and letting me go first. My niece and nephew are in town. They're actually in Trafalgar, getting ready to do a pottery thing, and I'm missing it. So that's where I'm headed next. So thanks a lot for letting me jump the alphabet and start at the end. For those who don't know me, I'm Kathleen Ratcliffe. I'm the Executive Director of Upstream Prevention. We are a local nonprofit that, there we go, seeks to support systems level changes to promote public health. Our mission goes on, but that's the core piece. And really what we're asking for funds is that systems level change here. So first, a little story. That always makes Wednesday mornings more fun. So imagine you're walking through the forest, enjoying nature, the trees. You come to a river and you see some individuals in the river struggling not to drown. Individuals on the banks that are strong swimmers jump in, swim out, grab them, pull them to the shore, and they're getting people to safety. And that's fantastic and great, but there are more people water than we have on the shore to get them help. And so then we have some individuals that take off running upstream. They see this beautiful waterfall, keep going, and they notice the bridge that would cross the waterfall has a lot of holes in it. It's got some gaps, wooden planks that are, rotted away, and individuals are falling through that bridge into the water down and having challenges downstream. What Upstream seeks to do, or our primary mission, is to fix that bridge. How can we find those systems changes? How can we find those extra boards, find those gaps, those resources that are needed so that it makes it a little bit safer upstream, so that then we have less individuals having challenges downstream. Probably the best version or example of this is our SOFR team. So SOFR stands for Suicide and Overdose Fatality Review Team. We started it in 2022, just focusing on overdoses. So at the time we called it OFR, now we call it SOFR. And the goal for a SOFR is really to look at individuals who have died, either by suicide or an overdose, and try to figure out where in their life previously did maybe the system, if it was tweaked a little bit, could we have had a different outcome? So we're identifying missed opportunities for prevention, trying to find those gaps in the system. We're building working relationships between stakeholders, again, focused on suicide as well as overdoses. And then as a group, we start making recommendations, either for policies, programs, different changes at the local or the state level, again, to try to prevent those fatalities from occurring. And then ideally, all of those recommendations get shared back and then things start to happen and changes start to happen. In Indiana, there's over 20 counties that have either a suicide fatality review team, an overdose fatality review team, or the combo like we do. We just added suicides in this year with a little bit of support from a state grant that allowed us to expand our partnership. But essentially, this group meets about 10 times a year. We say monthly, but we take off January because we meet the first Monday of the month, and that always falls right around the holiday. We miss September as well because the first Monday is a holiday. And then we typically will spend July doing recommendations. So it's less of a formal meeting, but it's still a gathering. And so we have partners from local law enforcement, treatment centers, the health department, EMS, JMH, adult and child, essentially anybody who might have information about individuals that can come and share information as we review cases. So ahead of each meeting, so our next meeting is next week, ahead of each meeting, we share a list of 2 to 3 names of somebody who has passed away, typically in the past year, from either a suicide or an overdose. We tend to divide our meetings by one type or the other. So next month, we're talking about overdoses. So we've shared 3 names of an individual who has died by an overdose. I don't remember off the top of my head their date of death, but typically at this point, we're looking at that first quarter of 2025, long enough for all of the data to get entered at that state level. We look up the publicly available information, like their obituary. We have a partnership with the coroner's office, so we get to see the death investigation report, the toxicology, and then we have a partner at the Indiana Department of Health that is able to get us some of the inspect data, some of the care web data from hospitals around the state that feed that information in. So we look at those types of things. We do a search on my case to look at justice involvement. And then if anybody in the room has access to some of that additional information, they can always share it. Some entities or some locations will do a next of kin interview. We don't do that at the moment because we don't have the capacity for it, but that is something that we've looked at and talked about. Once an individual has had a little bit of time to process the death of their loved one, sending somebody to go have a conversation with them to try to see what do they know that we don't? What is the personal information that they have that we don't have through just the data sets? And then we always end each case review asking if anybody else has any information. And so sometimes this, if you know somebody or you know of somebody who knows of somebody, some of our law enforcement and some of our court system partners know the family members, and so they can give some of that kind of background and detail. But we really just try to figure out what else are we missing in terms of information. And then we make a recommendation or make multiple recommendations usually. And so this is where everybody around the table is not picking on agencies. That's one of the rules, but it's identifying, oh, maybe we should have followed up with this person, or, do we have case managers in the hospital that could do these follow-up calls? So we start to identify what are those touch points. Where did this individual interact with a system somewhere that maybe we could have had a different interaction or something different, or an extra layer could be added on that would then change that trajectory. We also identify areas wish we had additional information. So again, this is where we're like, oh, I really wish that we knew what the girlfriend thought or the boyfriend thought, or, they had a child in the home. I wonder what their teachers, maybe they could provide that extra support. Right now, again, we identify where we want more information. We don't typically get it because we don't have the capacity to follow up and try to gather that. Ideally, at the end of each meeting, we have our list of recommendations and we pick out a couple that we want to either start on, or somebody in the room's like, oh, I can do that. Let's go forth. And then those recommendations get implemented. What I can tell you is I put up here a couple of recommendations that we've identified, the group has identified in the past that have already been implemented or have been started. So those are on the left, along with some things that we've talked about enough or we see every month that we would like to start to target. So on the left, EMS now, each of the EMS departments has a little bit of a resource packet or an information packet that they leave behind for any sort of non-fatal overdose. We also have a partnership or helped build a partnership. Upstream's not really as involved, between JMH and trying to get referrals to treatment for individuals that come in. If the individual is in the ED, we have a peer number that they can call and we can try to send a peer recovery coach to go talk to someone. But we don't have that staff 24/7, so it's kind of hit or miss. But from that ED partnership, there is a referral pathway in place where they can, EMS as well as JMH can provide information to our peers and the health department for their community health worker to go out, visit individuals, provide a harm reduction kit, provide conversations. If they're ready for treatment or want to have that conversation, help refer them to treatment. Those three things in existence all came out of this OFR back when we started. We also have an increase in naloxone and fentanyl test strips that are available around the county. The Recovery Cafe was partially instigated because of the OFR, and that's actually one of the entities that got funded in the first round. So thank you for that as well. We've also hosted several motivational interviewing trainings, and so these are trainings. We actually bring in somebody from Bloomington who's internationally recognized for being awesome and being an MI trainer. And it's really just helping individuals have better conversations. So we target this to providers, to the peer recovery coaches in the community, to clinicians. I'm trying to identify ways to help individuals, to meet individuals at the stage of change they're in and help move them along so that we can get them, they can make their own decisions to move on that healthier path. And then we've also started on education on overdose awareness, signs of an overdose, signs of alcohol poisoning, those types of things. That's something that we're always going to do because it just is always important. Some of the things on the horizon, I was messaging just to make sure, but that second one, the improved communication between agencies, this was identified as a recommendation in kind of general, but in reality, this is coming through the Julata platform. If you've heard of that, right now, I think it's being used mostly with White River Township Fire Department and Greenwood Township or Greenwood Fire Department and EMS to try to share information across systems, because it's really easy for one individual to get resources in one area, but we don't just stay in our geographic boundaries, right? So we move from boundary to boundary and being able to share that information about an individual across systems. I think there's plans or hopes that that Julata platform will increase and have more partners. And so that's, kind of that in process or in the horizon option. We've talked a lot recently about bereavement and grief support as recommendations. And so we have some pieces in place to try to start to expand support groups for individuals who lost a loved one to overdose, as well as just thinking in general and kind of that holistic manner that we don't have in Johnson County a lot of traumatic grief support. So whether it's an overdose or a suicide or just a car accident, right, or an unexpected death, we don't have great resources for individuals that are grieving. We don't have that statewide, but especially here, and that's something that we can work on. The next of kin interviews I mentioned was on our list of something to continue, as is the education and awareness. The transportation support I have like asterisk there, because in my application I made a comment about we might be able to supplement, if we get funded through this, we might be able to supplement it with some state funds. There is a state RFP that was released, RFP that was released specifically for opioid settlement dollars that had to be matched at the local level. So if we end up applying for that, it would be for transportation support. And so then that would be a recommendation that would be able to be implemented in in tandem with local dollars and state dollars. It's a competitive application. Who knows if we get it? We aren't actually sure if we'll apply. We just saw the details released this week, and I've been on vacation, so I haven't looked at them yet. But that's a theoretical recommendation that we hear all the time, is that, individuals are missing appointments because they can't get there. They're, not able to get to work sometimes because their car breaks down and they don't have, the money to fix it. And so just that transportation assistance for individuals in early recovery or to get into recovery. And all of that are just 6 months worth of recommendations. So you can see in the general, and that's not all of them. Those are the ones that were easy to pick out as things that we've either done, we've talked about or seen enough. And these were from the first 6 months that we met. So this was looking at essentially February 2022 through July 2022. Some of these happened really fast. And so like the EMS providing information, that happened literally within a couple months span. It was a recommendation that was brought up. Somebody in the room, one of our partners said, "Oh, I can do that." Built the sheet, built the form, printed a whole bunch, dropped them off at the EMS departments, and they were on the trucks the next day. Others take a whole lot more time, right? So building some of those connection pieces, hosting the MI training is not cheap, and so finding the money, coordinating all of that. Some of them take a lot longer. Some of them are super fast. What I think is not up here, but one of the things that I think I love most about the SOFR meetings is that we have powerful people. We have people with authority in their various agencies and departments, and they can hear that this is a gap. And they often just go back and fix it. And so that's always really great. It's a little less great because I find out about it, 6 months or a year later when I'm like, oh, that change happened. That's awesome. And happy that it happened. But the ability for individuals to sit and hear, oh, this is a problem or this is a gap. I can fix that and I can talk to my boss or I can talk to administration or I can just do it, that they can then make those changes immediately is pretty fantastic. I think one of the examples that stands out, probably strongest to me for that, one of our earlier cases, we reviewed an individual had died by an overdose and had been seen within an emergency department within 24 hours of their death. And so they were there for an overdose. They got taken to an ED. They, got Narcan, they were revived. They were there for a little bit. They walked out, AMA, and then they passed away a couple hours later from a repeat use. That death could have potentially been prevented if there had been somebody having a conversation with them, like a peer recovery coach, a community health worker, a social worker, somebody who was there having that conversation of there are options for you, there are paths forward. We had a JMH emergency department physician in the room. He heard that. We made a comment about, treatment can start in the ED if the physicians are willing to start it. There had been some changes with the DEA, and his question to me was, what do we need to do? And I was like, we'll figure it out. And then that's something that happened with JMH. They weren't ready to staff, and we weren't ready to staff a peer 24/7, but we got a phone number set up that they could call. We got a partnership set with a local treatment provider where JMH ED could initiate treatment, get them an appointment the next day at that treatment provider, and they could start that pathway. And all of that happened from the right people sitting in the room, having conversations and finding those gaps. So if funded, I just put these in with quarters because I didn't know when the timeline would start, what date, but looking for that first quarter to post a position. It would be a very part-time position. So we're just looking for the hours to coordinate the SOFR team. The State Department of Health has sample job descriptions, those types of things that we would probably use and modify. But getting that position posted, hired, trained, have them start to take over those meetings, host a recommendations meeting so that we can then figure out what of the recommendations we've already come up with, what are the ones that are most important or feasible that we want to tackle that specifically align with the abatement strategies, because that's something that we've asked for funding for implementation support. So identifying which of these things that we've talked about or something we want to tackle align with the funding allowed here, that we could then start implementation, continue that for the duration of the funding, and then ideally towards the end of that, host another recommendation meeting so that we have kind of a path forward for the next little bit. So the budget that we asked for was again for that super part-time staff, looking for someone who can compile all of that publicly available information, coordinate between our various partners, run the meeting, input the data on the back end, and then really that person who can oversee the implementation. Right now, all of this is falling on me. and I don't have enough time to do it justice. We had different coordinators when we started, but I have been trying to facilitate it since about November, December. And I am really good at a lot of things, but this is just one more thing I can't do because I don't have enough time. So I feel like we've really been lacking in the past 6 months, just because I haven't had the ability to dedicate time to it. And I'm confident that if we have somebody whose job it is to do this, and that's what they're focused on for a couple of hours, not only will the meetings run smoother and we'll have better attendance and more engagement, but we can actually then follow up on the recommendations and implement, which is where that hasn't happened near as much in the last 6 months. I can run a meeting, but it's that follow up and the herding the cats on top of all the other cats that I'm herding. It's a little challenging right now. And I think that's my last piece. Again, I mentioned that potential to be matched by the state. We submitted a letter of intent that was due by the end of June. But we submitted that letter of intent, like we might apply for this, but we had no guidance of what it would look like. The guidance that then and the actual RFP came out Monday, so we'll be able to look at that and decide. The one we submitted for was a transportation focused RFP to try to get additional transportation support for individuals in early recovery or working through that treatment process, which does align with the SOFR recommendations that we've seen. And so I think we'll be able to finagle it a little bit. I think they want that local match to essentially cover things that the state won't cover. And it's a dollar for dollar. So we'll have to dig through all of that, but potentially we'll be able to apply for that match. Oh, and so then ideally, we'll increase our attendance and functionality of the SOFR team. We'll have stronger implementation and follow-up of implementation of our recommendations. Again, specifically those that align within the abatement strategies, more efficient meetings and case reviews. I am not too ashamed to admit that I pull together all of our information, usually the Monday of our meetings. And so I'm a morning person. I skip the gym that morning and I work like 6 to 8. 5 to 8:30 to try to get it all gathered and that's when I usually find gaps in our data. And so getting that to be more proactive to somebody else, that'll help increase our efficiencies for those case reviews. And then ideally we'll have the ability to train and implement and actually start to utilize some next of kin interviews. We've trained a couple of people or had a couple of people trained in the past, but they've all been volunteers. And so then it's challenging to try to get volunteers to work in a super sensitive manner on the time frame that you need. And so trying to utilize this part-time person who could then also do those interviews would be great. And that's assuming that the training still exists, which we've heard that it should happen this fall. So we're keeping our fingers crossed for that. And then ideally we'll have decreased both fatal and fatal overdoses, and then just those increased involvements in recovery supports. If we're able to intervene before an individual dies from an overdose, then ideally we'll get them on that recovery path, be able to connect them better with treatment, recovery supports, just increased kind of general supports. I think that's my last slide. So I'm happy to answer any questions. I will say that when I leave, I am planning to join the Zoom. I think I can join the Zoom, but I am going to leave when I'm done. So you have however long to come up with your questions before I run away.
Okay, do Mike any questions?
Is this a total voluntary board? Everybody volunteers?
It is voluntary in the fact that nobody's telling them to be there other than their boss, right? So a lot of people are there on the clock. So like we'll have Heather from the CIT team. We have usually Tammy from CASA who's there. We usually sometimes we'll have somebody from the prosecutor's office. It depends on their court schedule. But yes, they come. They don't get any compensation other than the fact that most of them are there on the clock, if that makes sense. So voluntary in the fact that we invite them and then their boss may tell them they have no choice, but voluntary otherwise.
Jennifer?
Yeah, I think that you had mentioned that you applied for a state grant, so you currently have a state grant or you're applying, I get that you're applying for one. with, to match.
Yes, I would say.
But you received one prior?
Yes, so we currently have funding from the Department of Health under the Indiana Cares ECHO grant, which is focusing on overdose prevention. It is a grant that's about 95,000 a year that funds a lot of the work we do, but it does, and it has the ability to fund some things related to SOFR. There's just not enough money for us to then put towards it within that 95,000. That grant, fingers crossed, we'll have through next August. But we're waiting on getting our contract from the state, who's waiting to get it from the CDC. And a lot of the CDC staff, I think, that are supposed to be preparing that award, there's very few of them at the moment. So the award from the federal government to the state hasn't shown up, last I heard, and then the state won't give us an award to continue that until they know they're getting the money. So theoretically, fingers crossed, we'll have that overdose money through next August. But right now that contract or that funding ends this August.
Do you have any other, besides the grants, do you have outside partners that donate, businesses or individuals?
We do that for the most part for upstream overall. More of our funding comes from grants, either local, state, or federal. We do have some private foundation grants as well. We are a nonprofit, so we accept donations, but honestly, more of our donations tend to fall into that mental health realm, thinking suicide prevention realm versus some of our overdose prevention areas. So for individuals who designate where they want their funds to go, it tends to be more on that suicide prevention side or just in general. But we do accept donations.
And then one last question. So the number of people that attend your monthly meetings, how many people do you touch, I guess, for lack of better explanation? And then what's your retention? How many people come back?
So these monthly meetings, we were averaging really close to 30 or so. We've struggled more recently. And again, I think that that's something where having a person whose job it is to focus on that will increase those back up. We're currently probably closer to 20 or so, depending on the month. We do have good retention in terms of agencies that are retained. So then as people move or, as they might have to send somebody else, then the actual person changes, if that makes sense. So we've had, 2 to 3 people from the health department since we started, who's been our regular person attending. We've lost a little bit of our original EMS team individuals that were there, but we still have somebody from an EMS department that's there. So agency retainment or kind of that field retainment is really good. It just may not be that same person in the seat every month.
And what about the individuals that you're helping?
So that I think is a lot harder to count for a couple of reasons. So this group does a lot less of that direct face-to-face because we're looking at those system changes. But if you think about some of the recommendations that have been made, the individuals then that they're reaching is from it's not always upstream. So it's harder for me to get a count of how many EMS brochures were left, for example, other than the fact that I know that every EMS truck has them. And so getting some of that level of data is a lot harder. For the things that upstream controls or within our umbrella, I can typically grab better numbers of that. So I know when we think about naloxone doses that have been distributed out, we typically will put out either direct face-to-face or through trainings or through the nalox boxes we have around this county. We typically put out 250 to 300 doses of naloxone every month. And we've been doing that since probably late 2022. So we don't know often what happens with those naloxone in terms of are all of those getting administered or getting used, or is it individuals carrying them just in case? Because again, that gets that one step of data out of my control. If I had magic wands that I could wave around and make people give me data, we would have a lot more, but some of it's just really hard to get partners who are just doing the things that they're normally doing, but shifting how they do it to then turn around and give us data back.
Very good.
The only question I have, on here.
This part-time person, I assume,
would be part-time for years to come.
Ideally.
So do you have a plan how to pay for that in the future?
Somewhat. What I would say is that this time last year, I had lots of great plans of how to pay for things, and the world is very different now than it was then. Typically, these positions are ones that we can typically find grant funds for, or we can typically start to pull together partnerships. One of the things that we have not explored or done, but would be probably my solution if we needed it for this position, is to try to have some level of sponsorship pay in. So if we could, if we identify we need $50,000, can we find 10 entities that benefit from these recommendations that would, their systems are changing, and can we get them all to chip in? When I think of it, it's somewhat similar to a model that like Partnership for a Healthier Johnson County had several years ago. It's probably been a decade ago almost now, where each of the bigger health systems paid in to have a coordinator that then oversaw various things. The benefit is that I think we can pull off what we need with a part-time person who's just, hourly and has specific tasks to complete versus a full-time person. But part of it is also trying to find the right individual there. I think there's several counties around us that are also looking or have this done by a volunteer that we could probably, lean in together and build out. But right now it's hoping that we can find somebody other than me to do it. And if we can pull that off, then that frees my time up to then find additional funds or find that sustainability piece. I think if all else fails, right now it's me. So if we can't sustain the position, my hope is still that we would sustain the team, because I think it really is a valuable thing for the county to be able to pull together and to find those gaps and start to fix some of those challenges, oftentimes that we don't even know exist because we just assume that the system's working. And so it's not until we actually hold that magnifying glass up that we can say, oh, this is a super, super simple change. Let's implement it. And we have a huge impact on those individuals.
Very good. All right. Thank you, Kathleen.
All right. Thank you.
All right.
Have a good day.
Next up is Celebrate Recovery Center.
I'm Rodney Burton, with the Edinburgh Group, the Celebrate Recovery. It's not really a center. I'm not sure where that part came from. But we're a support group that meets. I'm the ministry leader. We meet in the fellowship building of the Edinburgh Church of the Nazarene. We've been meeting since February of 2018. This is our third location. The first place we was meeting ended up closing, and so we temporarily met at the Park and Rec building, and then we ended up here, and it's working out really well. Since we've been meeting here, our attendance has pretty much tripled. We've been in this location about 3 years. But what we'd like to do is Celebrate Recovery has material for younger elementary age kids and junior high to high school that the curriculum goes hand in hand with the Celebrate Recovery lessons for the adults. And so we want to target these kids to prevent them following in their parents' footsteps. A lot of times we've got, and for the ones under school age, we'd like to have start a nursery and some childcare for them, because we get calls pretty frequently asking if we provide childcare. There's a lot of people don't attend support groups because there's not childcare. We have each meeting, we probably have 5 or 6 kids that, people just go ahead and bring them. and they play in the back and, typically it's not an issue. But it does distract others and especially the parents that are having to, keep an eye on their kids. Unfortunately, some parents don't keep it on their kids and other people there do. Um, but some parenting education skills and things would be one of the event breakout topics. But our, let's see. A lot of these kids have, they've seen their parents Narcan. I mean, they've been through really traumatic stuff, and I've had to Narcan people at the meeting. It was a really sad deal because the kid had just got out of jail. He's like 19, and his mom and aunt supposedly going to bring him his wallet, but instead they got him high. And it's sad. This particular mom had already lost a daughter to overdose. And we need to break this generational cycles. But it's a touchy subject for me, I'm sorry, because I'm in recovery myself. I've been about 17 and a half years sober. 13 fentanyl was my favorite. But but like I said, a lot of these kids have experienced a lot of trauma. A lot of them have to fend for themselves. Even occasionally, we got one or two kids that come just because we provide a good meal. And we've been doing that for a long time. But these kids, their parents, a lot of times are, they're there, but they're not. I mean, they're neglectful. They're in the bathroom or the bedroom, nodding off. Or the parents not even home when the kid's there by themselves. And unless there's any new laws, it's been a couple of years since I checked. There's not really any age restrictions on, how old a kid has to be before they're left home. It's kind of, independent maturity level stuff. And, a lot of these kids that the parents are addicted, they got more street smarts and maturity, a higher maturity level because they've had to survive. Uh, Many of them get took advantage of. But this funding would allow us to, pay some people to lead these classes, to do the nursery, pay for the background checks, and because we don't want to just put anybody in there. We want somebody that can be trusted and is going to do a good job, and somebody that's not, oh yeah, I'll do that, and then 3 or 4 months later you're wondering where they're at, because that's pretty common, unfortunately, a lot of times. But the outcomes and measures, we do some pre-test and post-test assessments. And there's a adolescent opioid safety and learning scale, and a brief opioid overdose knowledge questionnaire. We would start doing a little better job of, tracking attendance and whatnot. We keep attendance, but just numbers, not necessarily uh, specific, groups or ages or, um, but, we'd like to start having some, uh, quarterly events, and trainings and education on, overcoming stigma. A lot of these kids are experiencing that even, because of their parents. They go to school and, hey, I see, why was your cops taking your parents off? Why is your mommy in handcuffs? Uh, some of the stuff's hard for kids to understand. But this curriculum will help them to, process this grief and trauma and learn healthy coping skills to deal with these issues. And it, we talk about recovery as a lifestyle. It's, you gotta get people to understand that they have to change their mindset about the drugs and that lifestyle. It's not just, oh, I stopped, I stopped using, I've been sober for 30 days. Well, if that's all it is, and you're still, breaking laws and doing criminal behavior and, not having a healthy relationship with your child, that's just minor behavior change. There's no real change. People that come to Celebrate Recovery and engage, they have relationships improve. They have just overall better quality of life, not just, oh, I'm sober now. Um, and, we provide Narcan through Overdose Lifeline and the state's standing order. We do more of those training and awarenesses. And the previous gal had mentioned the, suicide as an issue as well, and a lot of times it does go hand in hand with opioids because, when a person's addicted to opiates, they lose hope, and they think, a lot of times, well, this will end it, they just want it to be over. I've heard countless people tell me that. And, but I'd like to, train some of my other leadership to be just better equipped to have those conversations. In the event that I'm absent from the meeting that night. The another thing that we'd like to do, with this funding is get some new equipment. The computer we had and the speaker and stuff took a lightning strike, which it was outdated anyway. And Windows 10 support's coming to an end, as I'm sure most of you know, later this year. So we're going to have to upgrade anyway. And the speaker that somebody donated it works, but it's pretty small. We'd like to be able to get computer and sound equipment to be able to take these events outside, and that way people can hear it better, as well as during the meetings. I don't have to yell so loud. But we have a TV on the wall that we do our lessons and everything on. And we'd like to update that and get an enclosure for it, so that, because the church rents that facility out, during the weekends and at other times, and if somebody rents it and they've got kids in there playing around and a ball hits it or something and breaks it, the enclosure would help prevent that. And we'd also like to get a van for transportation. We've got a lot of maybe a third of the people that attend. We average 40 to 50 a week. And probably a third of those are justice involved, and are in the work release program. And a lot of times, some of them's not able to come because, the person that, or, the one or two people that have a vehicle, it's full and they can't fit no more in it. And we've got some people that attend the meeting that go up there and, and pick people up. But we'd be able to just provide transportation to them on a consistent, scheduled basis. But then also, apart from that, I think eventually these kids programs would would grow to a point that kids are coming, without the parents. Whether the parent comes or not, I believe the kid will come. And, some of these children will need transportation. And it would be done separate from, they would be picked up, and then the community corrections people, I wouldn't transport them at the same time. But I just feel like there's a huge need there in Edinburgh. I think just the last week or two, there was, I think, 2 overdose deaths. And it's just, we need to just break these cycles and, help the kids to not just, that they're seeing the dangers of it, but that's not enough to stop people. I mean, got parents who have lost kids to overdose, and the parents still use it. They brought it to the meeting for the kid to use. Kids that have seen their parents overdose. These are adult children, but or they lost a sibling or a friend, and that's not enough to make people stop. But when they come to Celebrate Recovery, they're welcomed in, they feel loved. And, a lot of times they continue to come even after they don't have to have their paper signed anymore. We got a lot of people who attend now that, it's been over a year since they've had to have any papers signed. They're still doing really good, still doing great, and still engaged. But yeah, I believe that's all I got.
Okay. Anybody got any questions for Mr. Burton?
I do.
Okay.
Mr. Martin, congratulations on this priority. You should be proud of yourself
Thank you.
and for what you do for that community of Edinburgh. I'm somewhat concerned about the budget because it also doesn't include insurance or of that van. You have to have insurance on your equipment and also in the van if that were the case. Just because of my background as an agent, that was not budget, so it's sketchy at this time. So just because of some items might have been left out, so I just wanted to email about that as well, make sure you're aware of
Yeah.
that.
Sorry, go ahead.
It's okay. I'm sure that the program is extremely worthwhile and is touching our lives. I would also, if I may, recommend that you reach out to some of these other groups that are presenting, that maybe they can assist you in some of your stuff that you need down there as well. Okay, because that might be a good to expand reach into the community by using some of these other groups too. That's all I have.
I think Todd hit on a good point, collaboration, not competition. So I think it works better for countywide. So Pam, go ahead.
I was asked if I knew who you were. My last name is Burton as well. There's a lot of us down there.
Yeah.
And I'm from that community, and your mom and dad are Ricky and Jenny, right?
Yeah.
Yeah. I watched you grow up and I know your story. And I know a lot of the people that have been involved in that program. I was there day one when it started. I've never participated in it. But I can tell and I've heard that you've put a lot of hard work into it. And sometimes it's hard to get up and speak in front of this type crowd. You could tell you were speaking from your heart, and I'm proud of you.
Thank you.
All right. Thank you very much.
No, we do partner with other organizations and things. We've got there's 4 or 5 other churches that get together, they provide the food. And there's a couple organizations that feed homeless, that any food. This past week, we had lunch meat and sandwiches and stuff. We had some left over, and they took it and fed the homeless with it. That way, none of it goes to waste. But
Yep.
thanks.
All right, thank you.
Thank you very much.
All right. Next, we have Infants in Bloom.
Stand this time, no slides. So we're going to pass out just a front and back progress report to kind of use to walk through today. I'm Dr. Holly Robinson. I'll probably spend just about 12 minutes, 15 minutes most going through, and then hopefully leave a little time for questions. So didn't do as much background. I'm sorry if anybody is new that wasn't here in December, but I think with the grant application, and you'll get a pretty good idea.
We have a couple. You might give a quick overview if you like.
It's just maybe not quite as in-depth as it was last time, so I'm sorry. Yeah, so what Infants in Bloom, and she's making sure the audience gets those as well. So we are excited. 7 months flies really fast. So we were one of the awardees back in December, but super excited to tell you what we've done in the last 7 months. So to remind everybody, we are an in-place medical practice. So think house calls is probably the easiest way to describe it. And we provide specialized care for infants ages 0 to 2 in their homes. Myself, my pediatric partner, and our nurse practitioner have all received specialized training. And we are in the home with our moms and our babies almost every week. So just to give a reference point, a typical pediatrician might see an infant who's been impacted by substance use, maybe 5 hours total in the first year of life, and that's probably on the high side. We're there more than that in 1 month. So we're there in the home, working with the families, working with the moms to do that. So that is the top. If we now move over to the top right of our progress report, what we're doing is we're trying to impact the long-term effects of that substance exposure. So over in the top right, you'll see the 11 known long-term effects of opioid exposure. So those effects there are specifically opioids, certainly alcohol, polysubstance, there's a lot more. And like Dr. Diamond has said, and love the way she says this, she's not here today with us, but was here last time. We won't be able to nurture away all of the impacts of the substance exposure. We know that, but the science is really clear. With intensive treatment, you can make a big difference in the outcome. So, again, we don't expect for these babies to be completely typical, but we know we can make a huge impact. And by partnering with some of the organizations I'm going to tell you more about, the research is missing. And so as we learn, we're able to do more, and we hope we can make a bigger impact. So you might remember in our last year's proposal, we said we were going to touch 3 to 6 infants and caregivers, and we to do that in collaboration with the Fresh Start program, which that's a Mommy and Me program. And that's run by the Volunteers of America. And we hope to be in 2 of their homes. One's in Columbus, Indiana, and one's in downtown Indianapolis. And so we hope to find moms from Johnson County who were there with their babies, participating in their program. And we have a memorandum with them, and we would provide all of this baby care with them. Well, despite every other week calls with the VOA, and they have been wonderful, there has not been one Johnson County resident to participate in their Fresh Start program. So the beauty of the program in nurturing care anywhere, said, well, what are we gonna do? Because there's no moms there. So as we told you, we weren't gonna start until spring. So January, we continued. Now I'm at the bottom of the page. But so we got the award in December. In January, we implemented our electronic health record and we got all of our 5 Medicaid contracts completed. In February, we started started meeting with as many people as we could in Johnson County. And it was pretty apparent that there were plenty of babies here. They just weren't in Fresh Start. And so in March, I hired our first nurse practitioner for Johnson County. And in April, we got our first 2 referrals. And so that referral was a foster mom who was taking care of 2 foster babies. One who was a newborn and their other baby who was 18 months old. And she would have loved to have been here today, but for privacy reasons, she can't do that. So if it's okay, I'm going to read her statement about her participation in the program. So she says we had some struggles when it came to feeding our first foster baby and had concerns that she was growing well. I worried that she wasn't getting what she needed. Thanks to Infants in Bloom with our second foster baby, it was a whole different story. The team came to the house on a weekly basis. Each time they examined her and checked her weight. They helped me develop a feeding plan to help keep her healthy, and they performed detailed developmental assessments that show she's thriving, which has greatly eased our worries. They have been available anytime I have needed them for questions via their app, and they constantly reassure me that I am doing well as a foster mom, which has made a huge confidence boost. I love that this program is still growing and evolving. I was asked to give feedback to make it even better. The team listens and adapts. The support that Infants in Bloom has allowed my family to be confident we are doing the best for our foster babies. In April, we got our first Medicaid reimbursements. That was part of our sustainability plan. So we have successfully billed Medicaid and are receiving that reimbursement. In May, we got 2 more referrals. We got one from a pregnant teen at Franklin High School, and we got another one through connection with Angel Care, which is a wonderful residential home in Johnson County. And so she delivered, and so we're seeing our 3rd baby is actually a resident of Angel Care. Just last week, we got our DCS contract, so that was another huge part of our ability to sustain. So we got one contract that's going to allow us to participate in a program they already have. So we'll just be a provider, and that program allows us to work with families, bio families. So those are the babies, actually, the families that still have the babies in their care. But they did create and they allowed us to create a unique program that's just for us. And so we can actually get funding to work with babies in foster care, so or wherever they are. So this is really critical because if you remember, part of our mission was to stay with these babies wherever they go, because these babies move. So they may go, they may be with a bio mom, something may happen. They may have to go to kinship care, they may go to foster care, and then they may come back. So in order for us to continue that continuity, it was really important that we got both of these DCS contracts so that we could stay with the babies. So you also might remember that Johnson County is one of 3 counties. So we are in Johnson, Jefferson, and Switzerland counties, providing and we are now just completed the first year of our 2-year pilot. So we have 8 infants total between the 3 counties. One pregnant mom down there we have one mom that just delivered. So we're hoping to get her baby when he comes out of the nursery in Switzerland County. And then we have another pregnant mom in Jefferson County. So hopefully we'll be up to 10 shortly. So we'll go to the back of the progress report. So even though you may remember, we're keeping our numbers intentionally very small because we're trying to optimize and make this program the very best it can be. And we're doing that with feedback. Well, first for practicing. So doing that with feedback from our families. So, and our community partners. And so if you look at the top right side, just a quote from me, we're creating partnerships that strengthens our model and amplifies our impact so we can offer infants and caregivers the best possible care. So the other things I submitted that we're passionate about is not duplicating services. So my mission is to keep our team very, very focused on what we do best, which is medical care, but also the care coordination. And that means using all of the services here. We've got a ton of services in Johnson County. We want to learn that. We're more than Jefferson County. We learned that. And so everyone, we're trying to leverage all those resources because we can do that better than we can. So, and I know you just spoke to that with the last person. So, Angel Care is doing amazing things. They amplify our services greatly. So I'm going to take the last part and just speak about the funding request because we took a bit of a non-traditional approach to what we submitted to you. So if you saw our budget, we didn't have a specific ask. We didn't have a specific dollar amount. We actually submitted to you the complete cost of providing 40 hours a week of care to families in Johnson County by using 2 nurse practitioners, my oversight as a pediatrician, and some part-time coverage from a nurse. So you have completely what it costs to provide that. And also we provide 24/7 call coverage like any doctor should. And again, that goes straight to us. As you heard from our foster mom, we have an app. We've seen lots of photos. We've seen a lot of spin, lots of images that come straight to us. It doesn't go through any kind of triage service. And that's been super important. We know that especially moms in recovery, and foster moms, right? There's just this high pressure to know what to do with your baby right away. So that's the approach we took. You all gave us $55,000 in December. And so that has enabled us to provide care to 3 to 6 families, as we said we would do this year. We also submitted the letter of intent to the state. So we have the opportunity to have 150,000 matched, so up to 150,000 matched. We are in the different bucket, so we're in preventative care and substance treatment. So whatever you do, we have every intention of applying for that match. So if given 50, we would turn that into 100. And that would allow us to provide more care to more families. I'm going to go above and beyond because what I want to point out is hiring a second nurse practitioner is an incremental. That's a big jump. There's just incremental costs of hiring a second person. But by hiring that second person, 24/7 call coverage is a lot for one person. But I do think if we were given somewhere in the, if you had the money to give us 75, we would turn that into 150. I think with the DCS, I'm fully confident the Medicaid reimbursement that we are getting in the DCS contracts. I really hope that we would be able to make up that shortfall because as you can see, our costs are higher than 150 to do that. So that was just the consideration. So I'm going to end at the bottom right. There is a quote from Lynette Sorrow. She's been a wonderful contact that we have made. She founded Generation O, which is an advocacy organization. She has 7,500 foster moms in her Facebook group that are parents of opioid exposed children. They tell us about the challenges of opioid exposed babies and what families need far exceeds the literature at this point. And she has every intention of partnering with researchers around the country to advance that. So I was lucky to get to meet her with researchers from Norton Children's, Cincinnati Children's last week. And she's doing just amazing things. Follow her on Facebook if you can to learn more about that. But her quote there is obviously we want to do everything we can do to help adults and every addict, but we're forgetting the children. Now I'm going to get emotional. I just want to thank you because we are in 3 counties. This is the only county that's gotten their act together to give out the opioid dollars that we're working in. So thank you. I think only 20% of counties in Indiana have done so. This money exists on the pain, because of the pain that these babies and people have gone through, and it's sitting in our bank accounts. So thank you. And you haven't forgotten the kids because you gave us money. So thank you.
Thank you. Any questions? Wow, you stumped the
I have
board.
one comment.
One comment.
I'm sorry.
Todd will.
I don't get to speak at home, so. I did not know the family that you spoke of participated, but I didn't feel. I said we, church every Sunday, they do have their hands full. We participate by providing, and by we, I mean, my wife, provides meals for that family once a week, I believe. And, they do have their hands full, so what, the work that you're doing is awesome, so.
Thank you.
Thank you.
Yeah, I didn't hear too much.
Next up is Terra treatment.
Good. I'm gonna come way down here for you guys.
Yeah.
Yeah, cool.
I actually just wanna, before I dive in here, kind of take my Terra hat off for a second, and just speak to you guys genuinely and authentically. As I'm a person with lived experience, I remember when the show, Dope Sick came out on Hulu, people would ask me if I saw it and I would just respond, I lived it. I injured my back in the late 2000s at the age of 18, was naive to all of this, and my life was changed drastically because of a prescription to a high-powered opiate. So coming to you today in this capacity is a real full circle moment for me. I'm a little nervous, but I think it's imperative for me as a person in recovery, the burden that you guys have to make sure that these monies are used appropriately and responsibly, not just for me, but for the friends that are no longer here today that I have as a direct result of all of this, right? So it's very important to me that you guys, take this responsible and do what's right. And so that's my soapbox. I'm gonna get off of it before I start crying. So yeah, my name's Caleb Lane. I'm the Director of Business Development at Terra Treatment Center. I went through that program in 2019, so I'm a living testament to the power and the magic that happens in that building and the services that we provide. For over 40 years, Terra Treatment Center has provided high quality, comprehensive treatment for substance use and co-occurring disorders in Johnson County. As a joint commissioned, accredited, and DMHA certified provider, Terra is recognized for its commitment to delivering evidence-based, client-centered care. Our team leverages clinically proven modalities such as medicated-assisted treatment, cognitive behavioral therapy, and integrated care approaches to empower individuals and families towards lasting recovery. Terra's mission is grounded in commitment to person-centered and compassionate care, ensuring every client receives a treatment plan tailored to their unique needs. This proposed expansion aligns closely with the advisory board's priorities, increasing treatment capacity, advancing evidence-based interventions, and strengthening community recovery resources. We have. Thank you. This proposed program capacity expansion leverages targeted staffing increases to enhance the scope and effectiveness of outpatient substance use disorder care for adults in Johnson County, prioritizing individuals with opioid use disorder, IV use, chronic relapse history, and co-occurring mental health conditions. Funding will allow Terra Treatment Center to serve an estimated 100 additional clients annually in its partial hospitalization and intensive outpatient tracks. Our modalities now in our current outpatient service are case management, recovery education, referrals to higher levels of care, and our annual caseload is about 130 adults. So you're seeing a drastic increase in the number of people we're going to be able to serve with this. We typically serve about 55% males, 45% females. 50% of the people that we serve are homeless, and 30% of them are justice involved. The addition of one-time full case manager and 2 part-time peer recovery coaches will yield measurable improvements. Our case manager will be able to develop individualized aftercare plans, connect clients with housing, employment, and legal support, track progress towards recovery benchmarks, and ensure care continuity alongside therapists and our clinical supervisor. The peer recovery coaches will be able to be certified through the Indiana peer recovery process, facilitate evidence-based peer support groups, draw upon lived experience to reduce treatment disengagement, and mentor clients with chronic relapse history, housing instability, and justice involvement. All staff will adhere to trauma-informed, strength-based practices and participate in multidisciplinary case reviews to maximize treatment integration. To ensure the maximization of funds, we will be utilizing existing PRN or part-time staff and offering them increased hours and compensation. So the peer recovery coach impact. I am myself a direct result of peer recovery coach. My last overdose, I woke up to a peer in the hospital. And as Kathleen spoke to earlier, I was directly involved in, Upstream's integration of peer support and JMH. So I know firsthand, what it's like having a peer walk alongside you through that journey. And it shaped what I wanted to do with my life and gave me purpose as well. Research shows that peer recovery coach contact is directly associated with 44% fewer hospitalizations and a 66% increase in utilization of outpatient services. Peer-led interventions generally reduce substance use, enhance treatment adherence, and improve self-efficacy and quality of life. The case management impact. Indiana's DMHA defines recovery supports to include case management. Case management is to include employment help, housing assistance, access to legal advice, etc. These services have been directly linked to a reduction in acute care utilization, increased continuity of outpatient services, and an improvement in social determinants of health. While maintaining broad eligibility for all adults with SUD, outreach and intake will emphasize the following: individuals experiencing homelessness or housing insecurity, adults with chronic relapse or co-occurring mental health conditions, and justice-involved persons, including referrals from our local correctional system. So mitigating the substance use disorder harms, we're talking about expanded access. So increasing the outpatient capacity through additional staff will allow us to treat an additional 100 clients annually, reducing relapse and overdose risk, and supporting MAT adherence and long-term sobriety. When we talk about relapse prevention, peer recovery coaches provide ongoing mentorship, emotional support, and community connection, all of which are proven to reduce relapse and improve long-term recovery outcomes. Social determinants of health. The full-time case manager will work directly with clients to address key factors such as homelessness, unemployment, and legal challenges that frequently exacerbate substance use disorder and increase the likelihood of relapse. Our justice-involved individuals are at a higher risk of overdose and relapse when recently released from incarceration. This project ensures timely engagement and continuity of care. Something that's really cool that we do at Terra Treatment Center is outcome tracking. So data. Through the use of a Track9 informatics, client outcomes are closely monitored across clinical, emotional, and behavioral domains, allowing for proactive treatment, individualized adjustments, and measurable progress tracking. So this system that we use, it's a short survey. I say short, but it takes them 10 minutes to do. They do this weekly. We're able to get alerted based off their answers of that. Hey, this person is at a higher risk of relapse. So we're tracking data, we're tracking outcomes. 6 months after someone leaves our care, they're still doing these surveys, and we're able to see how they're doing. We're able to alerted, of any kind of high risk situations. It's really, really cool. So our strategic alignment. So our targeted outreach and engagement. The expanded program amplifies the resources for high-risk individuals with the most pronounced access barriers. 53% of Indiana's incarcerated individuals have a substance use disorder. Our peer support infrastructure, our peer recovery coaches with lived experience and the state of Indiana certification will drive participation, engagement, and increase support offerings while boosting motivation. It's a lot easier for someone with lived experience to relate to what an individual is going through in that moment. Our service capacity. Our funding will immediately support expansion and access to integrated care. With the infrastructure that we already have, it'll be really easy to build this out. System integration. Collaborative relationships with Johnson Memorial Health, Johnson County Probation, and other local service providers maximize resource integration and that continuity of care through improving wraparound services and increased post-discharge engagement. And again, as stated before, Terra utilizes Track 9 informatics to monitor clients using predictive evidence-based analytics covering resiliency, pathology, and co-occurring disorder markers. These assessments are given at admission, weekly, and at discharge, as well as for 1 year post-discharge, and are utilized in treatment planning. So our budget overview. Salaries are calculated using internal compensation standards aligned with similar nonprofit clinical roles in Indiana. Expanding part-time staff member to full-time for case management. Our peer recovery coach compensation is based on our current PRN rates, transition to part-time roles with enhanced responsibilities. And training expenses include onboarding, required certification courses, and continuing education in line with state and Medicaid requirements. So when we talk about sustainability, right? Medicaid reimbursement. All new staff will be credentialed and trained in accordance with Indiana Medicaid and DMHA billing requirements. This ensures peer recovery services and case management become billable, sustaining operations through third-party payers. Budget integration. Salaries for expanded roles will be incorporated into the organization's annual operating budget beginning in year 2, overseen by the Director of Financial Services and our CEO, with quarterly reviews by our board of directors. Ongoing grant pursuit. Terra will pursue additional support through DMHA grants, matched fund opportunities, and private funding aligned with workforce and recovery initiatives. And performance-driven funding. This program's outcomes, monitored via the Track 9 platform, will be used to demonstrate impact and attract future investments tied to results and system-wide improvement. It's easy to garner more funding when we can show, the success we're having with this. So in conclusion, the need is urgent. Demand for outpatient services consistently exceeds available capacity, leaving many local residents without timely access to recovery support. Expanding staff resources will enable us to extend care to more individuals at a critical juncture and further the board's vision of responsive, high-impact community intervention, increasing treatment capacity and advancing evidence-based interventions. Meanwhile, strengthening community recovery resources.
Okay, thank you, Caleb.
Yeah. Well,
Thank you for sharing your story.
yeah. I remember feeling very honored when I was invited, I think when this whole thing was getting together 2 years ago when you were in that room. And just what it meant to me as a person to see your level of compassion for this and spearheading all this. And now we're here, right? So thank you.
Government works slow, but we're trying to speed it up. So everybody up here has really contributed to this. Anybody got any questions?
What approximately the number of patients or individuals that you, of the 130 that you said currently, approximately how many are from Johnson County? Because you serve, or you have people that come in from all over the state, I assume.
So our outpatient services are specifically for Johnson County residents.
Okay.
Yeah. We offer the IOP, but it's held here in Franklin. So usually folks are local that attend that. Yeah.
Anybody else got any questions? All right. Well, thank you all for coming. Hello, Judge Lloyd. Thank you for joining us today.
So, 2 minutes.
2 minutes. We got to hear the judge.
Thank you. I think most of the committee knows who I am, but if not, and for the audience, if you will, Judge Mark Lloyd, Franklin City Court, previously, Johnson Circuit Court, also a state senior court judge. First of all, I have, over the past couple of years, certainly been an advisor informally, to Infants in Bloom, a unique organization, fitting a much needed niche, in this area. They provide high quality care and help the most innocent of innocents. So, anything you can do to assist them, I think would be valuable to the Johnson County community. I would have to say as well, with regard to terror, I have probably sent hundreds, if not thousands, of individuals into their care for rehabilitation, and other services, some forced, some not. But over the years, they have provided Ann First, Teresa, the entire organization, quality care, for those struggling with recovery, and anything you can do to help them, I think, is a huge help, to Johnson County and certainly the judiciary as well. So thank you for your time.
Thank you for your perspective from the bench. Means a lot. Okay, I have one other one and I'll take the heat for this. It was a he said, she said, Tiffany and I were not, stars weren't aligned on that, was Riley's Children Care downtown. We supported him last time. Adam Kegley spoke with him, had a good conversation with him. He was unable to make it today. So I just wanted to put that on the board's radar screen also. So what, just so you're aware of what we're gonna do, we'll go back and discuss this and figure out, and then we'll make recommendations to the Board of Commissioners. And on July 28th, which is next Monday, we'll make those announcements at the meeting. So we will do that and everybody will be informed of what we've done and how we're doing it. But I do want to appreciate everybody sitting here. I know your heart and your passion is where it should be. And I appreciate the efforts that you guys do with this. So with that, I'd move for, well, I can't move. You somehow moved. Okay. All right. We are adjourned. Thank you, everyone.